Remember, today we will discuss about various patterns of HRCT and COVID radiology. So let us start. So this is how the various structures look in a city, HRCT. So let us try to identify. First of all, let us go through anatomy part little bit. So here you can see this hexagonal structure is secondary lobules, and this is pulmonary artery. It's always run parallel to bronchioles and alveoli, and this is perilymphatic area. Perilymphatic area contain pulmonary artery and pulmonary vein and septas. So this is how you can make out. Here you can see that this bronchus, it contain air, high potence air shadow inside it, and parallel to it is a pulmonary artery. So we this is how we can recognize differentiate, recognize a bronchial pulmonary uh, artery, and other structure which is not paired by bronchus. They could be pulmonary veins, and septa can also be seen, but septa are visible in some kind of pathological conditions. So now let us discuss about various opacities which can be seen. So first is ground glass opacity. You might have seen this kind of glass. You can see not very clearly through it. You can see abraded glass appearance. So this is how we can define an GGO, ground glass opacity. So here you can see, remember this part is actually denser than other part of the lung. So it could be due to interstitial space, alveoli, and or maybe pneumonia, infection, pulmonary hemorrhage, alveolar proteinosis, and so this is pneumonia and also COVID pneumonia. And this is how this slide is to demonstrate that GGOs can involve the larger pattern. So you can here see that this is the normal lung, and this is a lung of increased density. And let us proceed. So now next opacity you can see are the bullas. Bullas are the nothing but area of lung destruction. Here where no gas exchange take place. These are seen in emphysema, most commonly in smokers. So they have very thin wall structure. They could be distributed all over the lung field, and I on the basis of that we can classify various type of emphysema on the basis of HRCT. So here I have intentionally placed a slide just to demonstrate paraseptal emphysema. In paraseptal emphysema, you can see the distribution of bullas are at more at periphery, or they can rupture to form a spontaneous pneumothorax. So next is interlobular septal thickening. So as I told you, the septas are not usually visible in normal HRCT, but in some pathological condition, and they may become highlighted. So now next section is honeycombing. Honeycombing is basically due to dilation of the terminal bronchiole. Bronchioles are not visibly at periphery or at other areas, but when there is a dilatation of these bronchioles, they form a typical honeycombing type of pattern, as you can appreciate here. So this is highly suggestive of bronchiectasis. Now next come another signet ring sign. This is the characteristic feature of bronchiectasis, where you can see here bronchial dilation. Okay, and as I told you before, that bronchial artery and the bronchioles and pulmonary artery always run close and parallel to each other. So under such circumstances, if the terminal bronchioles is dilated, so it gives a signet ring structure. So the ratio of the bronchus to pulmonary artery should be greater than 1.5 if you in order to call it as a signet ring sign. So this is the criteria. You should not forget this. So next pattern comes crazy paving pattern. So friends, you might have seen that tiles on the floor looking like these are crazy paving. So this is how this pattern got its name. So here we can see more clear picture. So this is crazy paving pattern. Actually, crazy paving pattern is nothing but here you can see interlobular septa got highlighted, and even below that, these are the areas of ground glass opacity below this. So ground glass opacity, this crazy paving is nothing but the combination of this GGO pattern plus this. So suppose if I combine both these pattern and I superimpose both this, so they will look like crazy paving pattern. So let me demonstrate it with a video. In this video, I have tried to take some pixel from this and post it over here, as you can see in the video. Here we go. You can see here, I am trying to paste this opacity over this area, and we go. What I'm trying to convey with this video is just trying to convey if these two patterns get superimposed, they give a pattern of crazy paving. So crazy paving is nothing but the combination of interlobular septal thickening and GGUs. As you can very well appreciate here, it's not very much clear due to some technical problem, but you can understand. So remember, this is another pattern, tree in bud appearance. So usually bronchioles are invisible, and when there is a some kind of infection, especially tuberculosis, these are being plugged with mucus and pus fluid, and these plugs look like these kind of buds. This picture is taken from a tree, just to for demonstrating the tree in bud appearance. Here you can see the buds. So now let us check how it's look in a HRCT. So here you can see these are the birds, and here in HRCT you can see this appearance. This is seen in the and TB, tuberculosis, and some other condition, also infective conditions. So now next, you can see this secondary lobule again. So this pattern, central region is we call it centrilobular area, and this is perilymphatic area. Here you can see tree in bud appearance. You can see this terminal bronchioles are getting like this. So this is let us move. So now another best pattern is nodular pattern. So here you can see multiple nodules distributed all over the lung fields. So here is another pattern, another slide of same pattern. Here you can see multiple nodular pattern scattered all over the lung field, and most commonly seen in miliary tuberculosis. So next is consolidation. Consolidation means solidification of some part of the lung. So here consolidation could be of two type. One is involving the entire lobe. You can see here the entire lobe is involved. But here we can see some airways over here, and these bronchioles and tertiary bronchioles. Here the air get trapped inside that. That's why it's giving appearance like a tree and bud, and they are getting prominent in a consolidated area. But here you will not see the bronchus because they look hypodense. So this is the entire lobar consolidation, and in other cases you can see patchy consolidation. These are patchy consolidation. Especially in COVID, you will not see lobar consolidation, or rather you will find the patchy consolidation like this. So this is how can we differentiate the ground glass opacity and consolidated. Ground glass opacity are, in ground glass opacity, this secondary lobule get partially filled with fluid, and we can see the uh, vessels across the this opacity. But when later when this disease get progress, these ground glass opacity get converted into consolidation. So here you can see this is totally solidified, so you cannot see the underlying vessel. Okay, so you can differentiate easily between. So here I have this is a slide. So this might be, for beginner, this might be looking like normal, but this is not normal. You can see it is involving a large area over here. Okay, so at the periphery is pairing. periphery is pairing, so this is normal. So this is the GGO, ground glass opacity, and you can still appreciate the bronchovascular markings below it. But in consolidated page, you cannot appreciate any underlining structure. Rather, you will see a air bronchogram sign, as I told you before. So next is this is mixed pattern. Here we can see both ground glass opacity and consolidation. So this is slide taken from a COVID patient. So let us see. Now here you can see some grease pattern and a higher density, as I told you, and you can also see vessel across it. So this is the ground glass opacity. These all are the ground glass opacity. This is also ground glass opacity, because you can see this underlining vessels. You can easily see the underlining vessels. So this appears more brighter or hyperdense. So no at all sign. So let us understand what is the at all sign. So let us remember, before understanding at all or reverse at all, hello sign or reverse hello sign, let us understand one thing. So as you can see, I have previously taught you that this is the ground glass opacity. So after some time, it will convert into a consolidated patch. So consolidation may start from the center or may from the periphery. So how it's got its name? Uh, Suppose it start from the center. So you can see I am marking here. So suppose consolidation start at the center. So it will become brighter and opaque. So we will call it as halo sign, because we can see a central portion of consolidation is surrounding ground glass opacity. So this is how to differentiate. So as I demonstrate, you can see multiple consolidated patches over here. So it's 5 inch. Look here, you can see the area of central bright, brightness or hyperdense area surrounded by a GGU. So these are the atoll sign. Here you can also see on higher magnification. So this is the atoll sign. This is suggestive of organizing pneumonia. And now let us look at the reverse hollow sign. As I told you earlier, that the solidification will start from the peripheral region. So here you can look, zoom also at peripheral. So we call it as reverse hollow sign or atoll sign. Atoll is a ring shaped coral reef island from where it got its name. Now, other important things which most common in the COVID pneumonia. As disease progress, we can see linear opacity from the bronchial margins, and these are due to the bronchial dilation. So usually bronchus are not visible, but here you can see in cut section, these are the hypodense shadow bronchial. So this is due to bronchial shadow, bronchial mm, dilatation and linear shadow. You will find in COVID cases a lot of these kind of opacities. So let us move toward the COVID radiology. So here the most important finding will be the GGOs and consolidated patch are the most important findings. These are seen in almost 100% of the cases. And other findings that could be seen could be interlobular septal thickening, halo sign, reverse halo sign or atoll sign, crazy paving, linear opacity. I have demonstrated every all these. So So as a yeah, you can see GGO involve almost 100% area, and later it involved multiple lobes. So and consolidation in, we can see consolidation in 77 cases, and similarly here you can see. So this is these are the changes during 0 to 4 days. You can see GGOs, and other patterns also. And as disease progress, you can see that these ground glass opacity or consolidated patch will start extending and start involving various lobes. And after that, then day 8 to 10, you will see that the consolidation. These tissue will start become solidify, or consolidation will start appearing. And last stage is absorptive state, and in which all these changes get disappear. And this most important thing is negative feature of this COVID pneumonia. So negative feature is pleural effusion, lymphadenopathy, lung nodule, lobar pneumonia, train bud obesity. So if I say that these are the negative features, that doesn't mean that they cannot be seen in the COVID. Suppose the patient is already having a tuberculous pleural effusion and having lymphadenopathy or other thing. So if he develop COVID pneumonia at the same time, so you can see pleural effusion and other pre and bud opacity, but that doesn't mean it is directly due to the coronavirus infection. It is due to some other pathology. That's exactly I want to convey here. So let us discuss about Co-Rads classification, COVID reporting, and data system. So this was post classification system for the radiologists in the Netherlands, and still work in the progress, because this virus is new, and still we are gathering more and more information about it. So according to Co-Rads classification, we can classify the various CT from Co-Rads 1 to Co-Rad 5. So let us understand. So in Co-Rads 1 and Co-Rad 2 are usually non-COVID. So here I would like to demonstrate that what is Co-Rad 1. In Co-Rad 1, either you will find a normal CT, there is no abnormality, or you will find a non-infectious diseases. Like you can see CHF, you can see cardiogenic pulmonary edema, malignancy, or like that. So, but there is no pathology, infective pathology. And in Corads to any kind of CT which show infective pathology, either of bacterial or fungal infection, and but not viral pathology, is classified under Corad 2. So Corad 1 and Corad 2 also considered as known COVID. So let us move further. This section is taken from a patient having an infection, bacterial infection. Here you can see the other this right lung is not at all involved, and the upper portion of the left lung is not involved. Here you can see basal area is involved, and this is most commonly seen in bacterial pathology. So we can say here that this is non-COVID or Corad 2. This is not due to viral pneumonia, COVID pneumonia, because in COVID pneumonia it involves multiple uh, lobes, and opacity will be scattered. It will not spare any lobe or any reason like this. So this is So now let us discuss about Corads 3. Corads 3 means indeterminate or unclear, where the radiologist is not sure whether to classify the particular type of CT under COVID, or he should rule out COVID. So this happen usually when patient present earlier within 5 or 6 days, and the CT changes are not that much prominent, but he is able to see some kind of opacity like consolidated patch or GGU occasionally 2 or 3, and in that case could be disease will be in the progressive state. So instead of calling it as a non-COVID, you will keep it under Corads 3. That's indeterminate or unclear, because it can happen that within few or 3 days the pneumonia can progress, and then that's why they have to keep it under unclear. So let me demonstrate with a CT clip. So this patient was presented with a positive history of COVID. He has a contact, not positive history. He has a history of contact. Some of his family members were always COVID positive, and he also developed the symptom like fever and cough, dry cough. So he visited on, I think, 5th or 6th day. So let us play this video and understand what are the pathologies. So here you can see any pathology. These are the normal structure, bronchiovascular structures, and this is the. So let's play the video. So here we know that patient has high chances of having COVID, but here we can see one opacity. Okay, so let us go complete. And as I told you, if we see occasional opacity and one or two obesity, and patient has a positive history of contact and like that, then in case we cannot exclude the patient. So this is, we will classify this case under uh, unclear or indeterminate. So as we scroll, you have, yes, you can, if you just zoom the screen, you will see this is the consolidated patch, and here is the air bronchogram sign also. So it is better not to exclude the COVID, not to make the, we cannot make the diagnosis with confidence. So we will keep it under Co-Rads. It hardly matter whether you see a single or multiple kind of opacity, two or three opacity. But if I'm not very sure about COVID, then it is better to keep it under Co-Rads 3. But this is the CT slide of same indeterminate or Co-Rad 3. Here you can see I have just demonstrated. You can see this is GGO, ground glass opacity, occasional. So let us move further for Co-Rad 4. So in Co-Rad 4, it is a confirmed case, highly suggestive of COVID pneumonia. You will see multifocal GGOs or consolidated patch scattered around both of the lung field. So it will be involving almost all the lobes of the lung, and there could be a mixed pattern like GGOs and consolidated patch. You can see other findings also like interlobular sector, septal thickening, linear opacity, crazy paving also. So these are highly suggestive of COVID, CORAD 4, and let us move toward the, let me demonstrate with an video first. Now this is a video. Let us COVID patient. So here you can see that these are the GGO started appearance at the very earlier, and as we scroll down, we can see multiple GGOs along with some consolidation, multiple GGO distributed all over the lung field. Okay, it will not spare even a single lobe. Here you can see now they started appearing more and more. These are the GGOs. Okay, so we are highly, this is highly suspicious of COVID pneumonia. So as you can see here, more and more involved areas are there. This is of same patient coronal section. Here you can also notice the ground glass opacities, and along with some consolidated patches also are there. So here you can see. Let us move toward the next. So next is Corads. So here you will also see the multifocal GGO or consolidated patches scattered all around the lobes, all over the lungs, involving the multiple lobes and other opacities also like ground glass appearance, or sorry, like other opacities like linear uh, patches or crazy paving or like that. Now here you can see the predominantly they will involve the subpleural posterior basal region that differentiate Corad's 5 from the Corad. Both are the COVID, but we call it is very highly suspicious of the COVID pneumonia. So let me demonstrate with that video. Now let us see the CT type. You can see some cities are appearing here. You can see a large GGU patch along the directed linear opacity GGU patches over here, and let us now you can see here. You can see here these are the dilated bronchioles. You can see the air inside uh, these bronchioles. So these are the linear opacities, and other are these GGOs. All are the GGOs. So you can see the uh, vessels uh, uh, underlining the opacity. So these are all GGOs, and let us see. Now you can see there. One thing is this: you can see this subpleural distribution, peripheral distribution predominantly. You can see here also. We mark for you. So as you can see here, it's a plural or peripheral. Here you can also say predominant. And also these opacity have basal predominance. So as we move and we are now at the basal region, so opacity are more prominent over here. So here we can see that multiple opacities are seen, characteristic features of the COVID are seen, and predominantly uh, the predomination is peripheral, posterior, and basal region. So on the basis of this, we can classify them under Co-Rads 5. Now let you can see Co-Rad 6. It is nothing to do with the CT scan, and RT-PCR is a diagnostic uh, investigation. So if it's come positive, then we will directly give it as CROD 6, irrespective of whatever the changes are there in the CT. So that was enough for today, and I hope that this will be helpful for you in the future. Thanks a lot.